The field of cardiology has experienced remarkable advances in recent years, significantly enhancing patient care and outcomes. Today, we will explore these developments, focusing on recent randomized controlled trials, novel medications, updated treatment algorithms, and notable cases that have influenced our practice. These trials are the foundation of safer, more appropriate care and highlighting the progress in our field. In interventional cardiology, our mission is to evolve with the data from advances in imaging to breakthrough in drug delivery and procedural safety. These trials show how far we have come. Today, more than 60% of the cases are discharged the same day, a testament to the progress in the technique and technology. At Apex, we remain committed to delivering exceptional outcomes and leading the way in cardiovascular care. So my favorite trial this year, which highlight mechanical circulatory support in cardiogenic shock patients. There were several trials that came and they looked at cardiogenic shock. Cardiogenic shock still remains one of the leading cause of mortality in acute myocardial infarction patient, around 50% mortality even in today's day and age. There was the EuroShock trial and the ECLS shock trial showing improvement in mortality in cardiogenic shock patients with Impella, but with the use of ECMO, which is extracorporeal membrane oxygenation, it did not show any improvement. The biggest groundbreaking trial in this arena, in my opinion, was the DanGer shock trial that demonstrated that patient experiencing STEMI complicated with cardiogenic shock, the use of Impella CP device led to a staggering 12.7% absolute reduction in 180-day all-cause mortality compared to standard care alone. This translates to a number needed to treat on NNT of 8 to prevent 1 death. However, it's important to note that Impella group did experience higher rates of complication, including severe bleeding and limb ischemia, which is not surprising. We have known that when patient comes in with really big anterior wall MI and cardiogenic shock, we have been putting Impella device, but now we finally have proof that this is actually leading to mortality benefit. Obviously, current Impella devices are 14 French, so no wonder there is higher risk of bleeding and limb ischemia. The good news is we have newer devices coming that we can use via 9 French as opposed to a 14 French sheath, and a number of new companies are making these devices. So the future is very bright when it comes to cardiogenic shock patients, in my opinion. The other area where recent trials have highlighted is the efficacy of drug-coated balloon or DCBs in treating coronary artery disease, particularly in small vessels and diabetic patients. The Basket Small 2 trial, this was a great trial that demonstrated that DCBs are non-inferior to drug-eluting stent in managing de novo lesions in small coronary arteries with diameter less than 3 mm. Notably, DCBs were associated with significant reduction in major adverse bleeding events after 2 years, especially in very small vessels, suggesting a safer profile in higher bleeding risk patients. That is very important and interesting because the world of interventional cardiology started with plain old balloon angioplasty or POBA alone. Then came the stent for higher patency rate, and now pendulum is swinging back again where we are leaving nothing behind like a stent. We are doing a drug delivery through balloon only and getting the best benefit of the drug-eluting technology without having to leave a stent back. The other trial on this was the AGENT IDE trial, which was focusing on the in-stent restenosis or ISR patient. The AGENT IDE trial found that the AGENT DCB significantly reduced target lesion failure at 12 months compared to conventional balloon angioplasty, a difference of 7.9% versus 28%. This benefit was primarily due to lower rate of repeat revascularization and target vessel myocardial infarction, indicating that the potential of DCB as a superior treatment option for in-stent restenosis, and this has led to a treatment change where we have a patient with ISR, we are actually using more and more drug-coated balloon. These findings underscore the expanding role of DCBs in interventional cardiology, offering effective and safer alternative for patients with small vessel disease, diabetes, or ISR. Switching gear to another third trial, which was the Orbita 3 trial. If you guys remember, the original Orbita trial was looking at role of angioplasty in patients who have stable angina, and they did a sham procedure showing that angioplasty had more of a placebo benefit. But the Orbita 3 trial actually looked at PCI alone without the use of optimal medical therapy, because up until now, all the literature have been saying that PCI is as good as optimal medical therapy, which usually consists of very intensive beta blocker, vasodilator therapy, calcium channel blockers, etc. The question is, what about PCI alone as opposed to optimal medical therapy? And what Orbita 3 trial showed is that PCI alone, even without the use of optimal medical therapy, significantly reduced angina symptoms and improved quality of life in patients with stable coronary artery disease. The study showed a 38% reduction in angina and a 42% improvement in quality of life scores compared to baseline. These results mark a shift from earlier trial, emphasizing the direct symptomatic benefit of PCI as a standard alone therapy. This trial reinforces PCI's role in providing meaningful relief for select patients, redefining its value in modern interventional cardiology. The Prevent PCI trial, this to me is a very controversial but a groundbreaking concept, because we always have thought about role of angioplasty when a lesion is 70% or more or functionally significant. But on the flip side, we always talk about something called vulnerable plaque. Vulnerable plaques are this plaque which has a higher likelihood of rupture, leading to acute coronary syndrome, acute myocardial infarction, etc. So what Prevent PCI trial did is it explored the concept of treating vulnerable plaques, which are thin-capped, lipid-rich lesion, or TICFA, what we call it, which are prone to rupture and causing acute coronary events. Although this plaque may appear functionally non-significant, the trial demonstrated that preventive PCI led to an 89% reduction in major adverse cardiac events, including cardiac death, myocardial infarction, and hospitalization for unstable angina, a 0.4% event in this PCI group as opposed to 3.4% in the other group, making it a very significant difference. While promising, these findings do come with caution, as this practice is not yet adopted in the United States and pretty much worldwide, except these trials were run in New Zealand and Australia, and this does require further validation. But if confirmed, this approach could potentially reshape the guidelines, shifting focus from reactive to proactive coronary intervention. Anytime we go and do the angiogram and we assess if a plaque is vulnerable, whether it's 30%, 80%, you go and do preventive PCI. So time will tell us in this particular aspect. Another great area is intravascular imaging. We know intravascular imaging has become a cornerstone in percutaneous coronary interventions, offering detailed insight into coronary artery anatomy and pathology. The primary modalities include intravascular ultrasound or IVUS and optimal coherence tomography or OCT. IVUS employs high-frequency sound wave to produce cross-sectional images of the blood vessel. It provides deep tissue penetration, allowing visualization of the entire vessel and plaque morphology. IVUS is particularly useful for assessing vessel size, plaque burden, and guiding stent selection and deployment. OCT, on the other hand, uses infrared light to guide high-resolution image of the vessel lumen and superficial layers. Its superior resolution enables detailed visualization of the microstructures such as thin fibrous cap, vulnerable plaques, small intimal tears, etc. However, OCT does require blood clearance during imaging, requiring a higher use of contrast, and this limits its use in patients with renal dysfunction. So the trial that looked at imaging guidance is the Renovate Complex PCI trial. This was a great trial that evaluated the efficacy of intravascular imaging guided PCI compared to angiographic guided PCI alone, especially in complex coronary artery lesions. The study demonstrated that imaging guided PCI significantly reduced the incidence of target vessel failure, a composite of cardiac death, target vessel MI, or clinically driven TVR or target vessel revascularization compared to angiographic guidance. Specifically, the primary endpoint occurred in 7.7% group of the imaging guided group versus 12.3% in angiographic guided group, reflecting a relative risk reduction of approximately 37%. These findings underscore the importance of intravascular imaging in enhancing procedural outcomes during PCI, especially in complex PCI. By providing direct visualization of the vessel architecture, IVUS and OCT facilitate precise stent placement and optimization of the lesion, potentially leading to improved long-term patient outcomes. As technology advances and further studies validate this benefit, intravascular imaging is poised to play an incredibly pivotal role in interventional cardiology. I want to switch gears and talk about updates in medical therapy. It is an exciting time to be a cardiologist. The world of cardiology has seen remarkable advances over the past year, with groundbreaking research and new data reshaping how we think about medical therapy. From novel pharmacological agents to innovative therapies, these advances are transforming the landscape of patient care. The field of heart failure, cholesterol management, anticoagulation, antiplatelet therapy have all seen pivotal development. Additional therapies targeting specific populations, such as those with diabetes, amyloidosis, or high cardiovascular risk, have reached new heights, providing insight into precise medicine. Today, I'll highlight some of the most meaningful trials and innovations from last couple of years, which are poised to shape the way we practice medicine and bring renewed excitement to our field. Of course, GLP-1 receptor agonists. Within the world of cardiology, the SELECT trial that evaluated semaglutide 2.5 milligram dose in patients with established atherosclerotic cardiovascular disease but without diabetes. So these are patients who don't even have diabetes, because obviously GLP-1 agonist started in diabetic population, and now SELECT trial showed that even in non-diabetic, over a mean follow-up of 3.3 years, semaglutide reduced major adverse cardiac events by 20% and all-cause mortality by 19%, underscoring its potential to transform primary prevention in high-risk populations. The second one, which has been a blockbuster medicine for a while, SGLT2 inhibitors. We have seen its role in chronic kidney disease. We have seen its role in heart failure with reduced EF and heart failure with preserved EF. So the SMART-C was a meta-analysis. As we know that SGLT2 inhibitors like Farxiga and Jardiance continue to deliver broad spectrum cardioprotective benefit. The SMART-C meta-analysis confirmed this efficacy in reducing major adverse cardiac events across population with diabetes, heart failure, and CKD, showing additional real-time world data from the Danish registry, which demonstrated a 25% reduction in all-cause mortality in those with HFrEF using these agents. Another pretty interesting trial came in the world of PCSK9 inhibitor in the form of 4-year OLE trial. This 4-year OLE trial provided long-term data on evolocumab, showing that sustained LDL cholesterol reduction and continued 25% decrease in cardiovascular events over extended follow-up. This reinforces the critical role of PCSK9 inhibitors in lipid management and cardiovascular prevention strategies. Finally, after statins, which have been a blockbuster medicine, we're getting a new kid on the block, which is showing not only tremendous LDL reduction, but we are also seeing some hard endpoint reduction with this medicine. Another very exciting field of cardiology and very new is amyloid cardiomyopathy. This is a very severe disease and unfortunately extremely under-recognized. Now we are learning more and more about it, and we have finally some incredible treatment therapy. So vutrisiran is a new medicine for ATTR amyloid cardiomyopathy or transthyretin amyloid cardiomyopathy, and we saw a breakthrough with using vutrisiran, which is an RNA-based therapy. This trial showed a 35% reduction in all-cause mortality, along with not only mortality reduction, along with improvement in quality of life, functional capacity, marking a new era in amyloid cardiomyopathy treatment. Especially at the same time, we are seeing a lot of new modalities which can detect amyloid cardiomyopathy, whether it's a PET scan, whether it is cardiac MRI, or whether it's pyrophosphate scan. Heart failure, obviously, Entresto still continue to remain an incredible kid on the block. Entresto, which is a sacubitril valsartan combination. The new analysis of Entresto that came out, it confirmed benefit in reducing heart failure, hospitalization, and cardiovascular mortality by 20 to 25% range compared to the traditional ACE inhibitor therapy, further solidifying its place as a first-line therapy for heart failure. In addition to all this exciting new stuff, we also have some data showing stuff that didn't do. Colchicine in cardiovascular disease was another promising result with the earlier trial, and there was a lot of initial promise. Despite that, colchicine actually did not show significant mortality benefit in recent trial, tempering its enthusiasm over its routine use in cardiovascular disease prevention. But in conclusion, this trial and therapies exemplify how innovation and rigorous research are driving our field forward. As cardiologists, we are privileged to witness and contribute to this wave of advancement, which are not only improving outcomes, but also redefining how we approach care. The data we have discussed today will undoubtedly shape future guidelines, enhance clinical decision-making, and inspire us to continue providing and pushing boundaries in cardiovascular medicine. Let us take this insight forward and work collectively to translate these findings into better patient care for our patients. The future of cardiology is bright, and together we will lead it with excellence and innovation.